Hello everyone, I am Dr. Shagun Mehta. I am a pathologist by profession. A very warm welcome to all of you to Pathology Bites. The topic for today's discussion is Hodgkin's lymphoma. Now assume a clinical scenario in which a patient comes into your OPD complaining that he has multiple swellings in the cervical region. So the first thing that comes in your mind, you ask the patient whether these swellings are painful or painless, and to which the patient replies that these swellings are painless. And the second thing you ask whether these swellings are increasing in size or not, to which he replies that yes, they are increasing in size. Okay, so this gives us to the most common presentation of a patient of Hodgkin's lymphoma, that there is painless enlargement of the cervical lymph nodes. The second thing patient tells you that he has fever, but there is a peculiar thing about it, that he has fever for 1 to 2 weeks, then it comes to normal, and then again he has episode of fever, which strikes in your mind that the patient is having cyclical fever. Okay, the patient is having cyclical fever, which in case of Hodgkin's lymphoma is termed as Epstein fever. So this gives us a clinical picture of a patient of Hodgkin's lymphoma, that he will be having painless enlargement of the cervical lymph node and cyclical episodes of fever called as Epstein fever. Right? Now there is a very important MCQ that has been asked, that Hodgkin's lymphoma is associated with 2 paraneoplastic syndromes. Which are those paraneoplastic syndromes? Number 1, secondary amyloidosis. Secondary amyloidosis, that is AA type, and the second one is alcohol-induced lymph node pain. So this was an MCQ that has been asked, that which are those 2 paraneoplastic syndromes to which Hodgkin's lymphoma is associated. So the answer is secondary amyloidosis and alcohol-induced lymph node pain. Right? Now we move to the pathogenesis, to the etiopathogenesis of Hodgkin's lymphoma. So the Hodgkin's lymphoma, it is characteristically associated with EBV infection, that is Epstein-Barr virus infection. Okay, so what happens? This EBV virus has LMP1. What is LMP1? The latent membrane protein 1. Right? So this EBV has LMP1 on the surface. So what does this LMP1 do? This LMP1 attaches to the surface of the B cell, and it attaches to the surface of B cell via a receptor that is present on the B cell membrane. Again, a very important MCQ, that which is the receptor which is present on the B cell surface to which LMP1 binds? The answer is CD21 receptor, which is also called as, another important MCQ, which is also called as CR2 type receptor, complement receptor type 2. Okay, so this LMP1 which is present in the EBV, it binds to the CD21 or the CR2 type receptor that is present on the B cell membrane. Then what happens? It sends signals to the nucleus, right? It sends signals to the nucleus, which leads to the activation of nuclear transcription factor kappa beta. Okay, it sends signals to the nucleus that leads to the activation of nuclear transcription factor kappa beta. Now again, what this will do? This will lead to the overexpression of C-rel proto-oncogene. This will lead to the overexpression of C-rel proto-oncogene. So now the B cell, which was normal, but because of the overexpression of the C-rel proto-oncogene, has become neoplastic B cell. That's why Hodgkin's lymphoma is a B cell lymphoma, right? So it becomes neoplastic B cell. Now this neoplastic B cell has a characteristic appearance, right? So what is that characteristic appearance? That these neoplastic B cells, they are large with mirror-like nuclei and prominent eosinophilic nucleoli. Remember, I'm highlighting this prominent eosinophilic nucleoli. Why I am highlighting it? Because of these prominent eosinophilic nucleoli, they have an owl eye appearance. They have an owl eye appearance. And such cells with mirror-like nuclei and having prominent eosinophilic nuclei, having an owl eye appearance, are called as Reed-Sternberg cells. They are called as Reed-Sternberg cells or the RS cells. Right? Now I told you that owl eye appearance is because of the prominent eosinophilic nuclei in case of the RS cells. But now there's one more question, a very important MCQ, that this owl eye appearance is also seen in one another infection. Which is that infection? CMV virus infection. CMV means cytomegalovirus infections. In cytomegalovirus infections, we see owl eye appearance as well. But what is the reason of the owl eye in that case? It is because of the basophilic intranuclear inclusions. Because of the intranuclear viral inclusions, they impart the owl eye appearance. Okay. Now how a Reed-Sternberg cell would look like? This is a cell, right? These are the mirror nuclei and these are the prominent eosinophilic nucleoli. Okay. Now whether RS cells, if they are present in a histological picture, if we look at a section and we are able to appreciate the RS cells, whether the RS cells alone are diagnostic of Hodgkin's lymphoma or not? The answer is not. They alone are never diagnostic of Hodgkin's lymphoma. What is the reason why they are not diagnostic? Because RS cells can be found in other infections as well. Which are those infections? RS cells can be found in various conditions as well. What are those conditions? Number one, infectious mononucleosis, and the second one, non-Hodgkin's lymphoma. A very important MCQ. In which type of non-Hodgkin's lymphoma we can see Reed-Sternberg cells? So the answer is immunoblastic type of non-Hodgkin's lymphoma, we can see Reed-Sternberg cells. So what is the histological diagnostic feature of Hodgkin's lymphoma if not RS cells alone? So the histological diagnosis of Hodgkin's lymphoma is made by Reed-Sternberg cells along with background of mixed inflammatory cells. So alone RS cells won't be diagnostic, along with the background of mixed inflammatory cells. Mixed inflammation may be neutrophils, lymphocytes, plasma cells, eosinophils, any of them. Okay, so this was a basic idea of the pathogenesis and the histological picture, the Reed-Sternberg cells and everything. Okay, So now if we go back, and look at this picture, okay, I'm magnifying it for all of you. Look at this picture. What you can appreciate, a classical Reed-Sternberg cell, okay, a classical Reed-Sternberg cell. These are the mirror nuclei and these are the prominent eosinophilic nuclei. Isn't it looking like an owl eye? Yes, that's why they are called as owl eye appearance of the Reed-Sternberg cells, right? I told you owl eye appearance is also seen in another condition. What was that? That was cytomegalovirus infection. So again, see this is a cell giving an owl eye appearance, but the reason is because of the basophilic intranuclear viral inclusion. So this is a picture of CMV virus infection, right? Now we move further. So according to WHO, Hodgkin's lymphoma have been typed into two different categories. One is classical Hodgkin's lymphoma and another one is non-classical or the nodular lymphocyte predominant Hodgkin's lymphoma, that is NLPHL. So, a very important MCQ, that what is the basis of this categorization, of this differentiation? A very important MCQ. What is the basis of that differentiation? The basis is, the question is that the answer is immunophenotyping of RS cells. The basis for this differentiation is the immunophenotyping of the RS cells. So the immunophenotyping of the RS cells is, for classical Hodgkin's, is that they are CD15 plus and CD30 positive. They are CD15 positive and CD30 positive. And in case of non-classical, they are CD15 negative, CD30 negative, BCL6 positive, and BCL6 is a marker of germinal center, okay, and they are CD20 positive and CD45 positive. So these are the various CD markers, very, very important for the classical as well as non-classical Hodgkin's lymphoma, and the basis of this differentiation is immunophenotyping of the RS cells. Okay, now we move further. Now this classical Hodgkin's lymphoma is again further subtyped into nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. Now this slide is very, very important for all the PG aspirants since it contributes to a lot of MCQs. Okay, but don't worry, I'll take them one by one. So the first question that has been asked, that which Hodgkin's lymphoma, listen carefully to my words, that which Hodgkin's lymphoma carries the best prognosis amongst the classical Hodgkin. Okay, amongst the classical. So the answer will be nodular sclerosis, right? If a question is asked that which Hodgkin lymphoma carries the best prognosis overall, then the answer will be NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma. Okay, so the next question comes, which is the most common Hodgkin's lymphoma in the world? Again, the answer will be nodular sclerosis. But if the question is asked as which is the most common Hodgkin's lymphoma in developing countries like India, the answer will be mixed cellularity, right? And now, which Hodgkin's lymphoma carries the worst prognosis? We have done with the best prognosis. Now, which carries the worst prognosis? The answer will be lymphocyte depleted. And obviously, which is the least common out of all? That is also lymphocyte depleted, right? So, we read the best prognosis amongst the classical Hodgkin's. The answer is nodular sclerosis. And which carries the best prognosis overall? That is the non-classical or the NL-PHL. Which carries the worst prognosis? Lymphocyte depleted. And the most common in the world, again, the nodular sclerosis. And in developing countries like India, which is the most common? Mixed cellularity. Which is the least common? Lymphocyte depleted. Right? Understood? Now we move further. We'll deal each entity in a little detail. So first we will start with nodular sclerosis. Nodular sclerosis is generally seen in younger patients and it has male to female equal distribution. Okay? And generally the patients of nodular sclerosis, most commonly they present with a mediastinal mass. Rather than a cervical mass, they mostly present with a mediastinal mass. Okay? And what do we see in such cases? That if a slide comes to us, like if we see the histological picture of such patients, then even on the lower magnification power, we can appreciate the histological findings of such cases. Okay, now the name itself suggests, what is the name? Nodular sclerosis. What do you mean by sclerosis? Sclerosis means collagen deposition. Nodular means formation of nodules. So, nodular sclerosis means that there is deposition of the eosinophilic collagen bundles forming nodules, right? And this feature we can very well appreciate even in the lower magnification power. Okay, now look at this picture. Look at this picture. We can clearly appreciate these eosinophilic collagen bundles, right? Eosinophilic collagen bundles, and these are our nodules. Okay, we can clearly appreciate. Can you appreciate one more thing? That there are clear spaces. That there are clear spaces within these nodules. What are these clear spaces? It is nothing, just an artifactual finding. What happens when we get a case of such patients, we get the tissue of such patients, while paraffin sectioning, what happens that the cytoplasm is removed and what is left behind is a clear space or a halo or a lacuna. A lacuna is left behind. Okay, so that's why these cells are called as lacunar. These cells are called as lacunar RS cells. Okay, these cells are called as lacunar RS cells, Reed-Sternberg cells. Okay, so if we look at the higher magnification, you can beautifully appreciate these clear, nothing, just the clusters of the clear lacunar Reed-Sternberg cells. Okay. So there was an important MCQ which was asked in one of the exams that lacunar Reed-Sternberg cells are positive for with CD markers. So it is the same scenario. Question ऐसे पूछो या वैसे पूछो, right? And I told you lacunar RS cells, they are found in nodular sclerosis. Nodular sclerosis is a subtype of classical Hodgkin's lymphoma. And in the beginning only I told you that classical Hodgkin lymphoma is positive for CD15 and CD30. So what will be the answer? That lacunar RS cells will be positive for CD15 and CD30, right? Okay, so this was about nodular sclerosis. Now we move further to mixed cellularity subtype of the classic Hodgkin's lymphoma. So this entity, it has a biphasic incidence, which means seen in the younger population as well as in the adult, in the older population. Okay, males are more commonly affected than females, and there is a very important finding that these patients, they are more commonly associated with the B symptoms. So what are these B symptoms? B symptoms are like they have unexplained loss of weight, unexplained fever, and there will be night sweats. Okay, these are B symptoms, and the patients having mixed cellularity type of Hodgkin's lymphoma, they are more commonly associated with all these B symptoms. Okay, so there's again an important MCQ. Which infections are most commonly associated with this subtype of Hodgkin's lymphoma? So the answer, there are two main viral infections. Which are two main viral infections? One is EBV, one is EBV, and the second one is HIV, right? These are the two viral infections which are most commonly associated with this subtype. The question can be asked the other way as well, that HIV and EBV are most commonly associated with which subtype of Hodgkin lymphoma? Then our answer will be mixed cellularity type of Hodgkin's lymphoma. Okay. Now in this case, we find mononuclear type of RS cells. We find mononuclear type of RS cells, right? Mononuclear type of RS cells. The name itself suggests mononuclear, that means only one nuclei. Okay, now look at this picture. You can very well appreciate mononuclear type of RS cells having one nuclei. Okay, so along with mononuclear RS cells, they will be having mixed inflammatory background as well. As the name suggests, mixed cellularity. Okay, so now next we come to another entity, lymphocyte rich Hodgkin's lymphoma. Lymphocyte rich Hodgkin lymphoma, that is generally found in older male population, and in this case, what kind of RS cells we'll see? We'll see again the same mononuclear RS cells. Okay, but there will be few number of mononuclear RS cells and more will be the lymphocytic background, right? And it also carries a good prognosis. Now the last entity in the classical subtype of Hodgkin's lymphoma, that is the lymphocyte depleted. As I told you earlier, it is the least common, it carries the worst prognosis. Okay, and what type of cells, if we can see in this kind of Hodgkin's lymphoma, we see pleomorphic RS cells. Why they are called pleomorphic? Because they vary in size and shape. Okay, but sometimes what happens, that they may have basophilic deposition of calcium. They may have deposition of calcium, then they will be called as mummified RS cells. One important question. There was a question, Hodgkin cells are seen in. Okay, so Hodgkin cells are seen in, right? So the Hodgkin cells are seen in lymphocyte depleted type of Hodgkin's lymphoma. They are nothing, just the atypical histiocytes. Hodgkin cells are nothing, just the atypical lymphocytes, right? Now, this was all about the classical type of the Hodgkin's lymphoma. Now we move to the non-classical type, or the nodular lymphocytic predominant Hodgkin's lymphoma, NLPHL. Okay, so the patient of NLPHL usually presents a young patient usually presents with a cervical or the axillary involvement. Usually a young patient with cervical or axillary involvement. Very, very important MCQ which has been asked, that in these cases, in the patients of NLPHL, there is no association with EBV. Okay, no association with EBV virus. Okay, there is no association with EBV virus, and in such cases, the RS cells, which kind of RS cells are seen in such cases? They are called as LH cells. Okay, they are called as LH cells. They are called as LH cells, also known as lymphocyte histiocyte rich variant of RS cells, and they are also called as popcorn cells. They are also called as popcorn cells. Why they are called as popcorn cells? Because of the variation in the nuclear contour. What kind of variation? There are two variations in the nuclear contour that can be seen. One is multilobulated and the another one is polypoidal nature of the nucleus. Multilobulated or polypoidal nature of the nucleus. That's why they are called as popcorn cells. Okay. Now look at this picture, histological picture. Can you appreciate these popcorn cells? Variable nuclear contour, sometimes multilobated or sometimes they have a polypoidal nature. These are all popcorn cells. All popcorn cells, right? If you look at the higher magnification, again, a very beautiful popcorn cell. Okay, so these are the popcorn cells seen in the NL-PHL. Okay, now we come to the last topic. I have seen a lot of questions have been asked from the prognostic factors related to Hodgkin's lymphoma. So I have accumulated them all of here. I have accumulated them for you to make it a little simpler for you. Okay, so which are the bad prognostic factors that are associated with Hodgkin's lymphoma? A male patient, usually a male patient more than 45 years of age, having a hemoglobin level of less than 10.5 gram percentage, and if the lymphocyte count, which is generally a reduced, very less lymphocyte count. And precisely in one of the questions in the exams, there was a option that absolute lymphocyte count less than 600 per microliter, is it associated with a good or bad? So it is associated with a bad prognosis of Hodgkin's lymphoma. Likewise, there was also one of the options that the lymphocyte count in a differential lymphocyte count in a DLC, the lymphocyte count less than 8% of the total leukocyte count. Okay, another bad prognostic factor that the patient is having low albumin, that is generally less than 4 gram per deciliter, or the TLC more than 15,000 per mmQ. So that was all for Hodgkin's lymphoma and its histological variants. Thank you so much. Soon I'll be coming up with more videos. Thank you.